I'm the director of the Progress Educational Trust, which is a charity that was founded back in 1992 to improve public understanding of reproductive medicine and genetics. And we've been doing that ever since. And what we aim to do is to improve choices for people who are affected by infertility and genetic conditions so that they can have more choices about what treatments are available to them. Whether they choose to take them or not is a matter for them. And we promote the responsible application of science in a number of ways. By leading the debate, so identifying the challenging topics and encouraging public discussion about them through holding events. Influencing policy, so working closely with government, with organisations like the Human Fertilisation and Embryology Authority, so that it better reflects the interest of patients and also the people who work in the sector, so they can work in a sector, where they know what the rules are, so they have that sort of confidence in their work environment. And by informing and explaining, so by publishing our weekly email news digest, BioNews, and holding events like this one. Tonight, I think, is a really special event because there are so many amazing stories in the reproductive sector that, they deserve to be shared and to be retold and to be remembered and preserved. And this is our second event in a series of this type of event, and we hope to do more over the coming years. So hands up if you've heard of Louise Brown. So a couple of hands didn't go up. Hands up if you before tonight you'd heard of, if not before tonight you hadn't heard of, sorry, you had heard, I can tie myself in a knot. If you had heard of Alastair MacDonald. So you're quite famous. And he is the world's first baby boy born via IVF. And we're particularly delighted that his mother is here to tell the story about her experiences as one of those very first IVF patients. And I was kicking myself because on the train on the way up I thought, why didn't I ask Grace to bring some of his baby pictures? And we could have had them all up on the big screen. Anyway, Alastair is delighted that my mad memory is failing me, and I didn't think of that in advance. Anyway, but I'm sure Grace will share them with you if you probably, speak to her afterwards. So, in your packs, you've got lots of information about the panel. We've got a great range of experts, and you also have an evaluation form. We really like feedback on the events. And we're going to be doing more events in Scotland in 2019. And so our question on our evaluation form really is to pick your brains about what topics you think we should be covering up here in Scotland. We're going to be back in Scotland later in the year, as I said. But also, I must do my charity bit now, because I'm not speaking at the end. PET is a charity. And so we rely on people supporting us. So there's information in your packs about how you can make a donation, how you can become a regular supporter through our Friends of Pet scheme. And that's very much appreciated. So we're next back in Scotland in March, she says, yes, where we're going to be talking very much about the cutting edge of technology. A lot of research around that is being done here in Edinburgh. So that's going to be exciting. And we're going to be talking about genome editing as well and where we should go with that, because big ethical questions around that. So the Progress Educational Trust is delighted that Professor Allan Pacey, one of our trustees, has decided to, has agreed to chair this discussion this evening. So for those of you who don't know Allan, he's Professor of Andrology at the University of Sheffield and Editor-in-Chief of the Journal Human Fertility. And I'll leave you now in his capable hands.
Thank you, Sarah. Welcome to Edinburgh. Welcome to this, I think it's going to be a very unique event. As Sarah said, I'm Professor of Andrology at the University of Sheffield, and I'll try and keep my opinions to myself. I'm going to be the neutral host. Apart from yourselves, The important people tonight are on the stage, and I'm going to quickly introduce them, and we're going to spend about an hour talking with them, and then I'll open it up for questions. So if you have a question along the way, please note it down, and then we'll come to that in about an hour's time. So on the far right of the stage is Dr. Kay Elder. Kay's been a friend of mine, long-time friend for 25 years, a great host. Was born in Dundee. We share one thing in common in that we are both graduates of the University of St Andrews. But Kay, you were given your first job by, I think, Patrick Steptoe, or one of your first jobs, and you worked at Bourn Hall for many years, just outside Cambridge. She's written lots of textbooks on IVF, has written lots, but most recently has written papers based on the archives of Bob Edwards and Patrick Steptoe, and I think that's going to be a fascinating part of our evening. So welcome, Kay. To her right, your left, is Grace MacDonald, who comes from just outside Stirling. I'm pleased to say is a graduate of both of the universities here in Edinburgh. I seem to remember you telling me, from Napier and from the University of Edinburgh. She's had a career in further education, and she's here tonight because just over 40 years ago, she gave birth to the first IVF baby boy, as Sarah has just said. That baby boy is sitting to her right, your left, now 40. Alastair MacDonald, welcome. You're a systems engineer with the Merchant Navy, I think, and spends a lot of time away from the UK. I think you told me in the Middle East, so it's a great pleasure to have you here tonight and have you in the country. I think Glasgow is your current home. Yeah. To Alastair's right, your left, is Abha Maheshwari, who's director, person responsible and lead clinician at the Aberdeen Fertility Centre. Is that the right title? A clinician, but also a researcher, and has published many papers and is pushing our knowledge forward in many ways. Is leading the E-Freeze study at the moment. I think that's right, isn't it, Abha? To Abha's right, again, your left, is Sally Cheshire. Sally is the current, and I think the 8th chair of the Human Fertilisation and Embryology Authority. Lives just over the Pennines from me in Stockport. And the HFEA is the regulatory authority for IVF and other reproductive technologies in the United Kingdom. So, Sally, thank you for coming. And finally, but no means least, to Sally's right and next to me is Professor Colin Duncan, clinician, scientist here in Edinburgh, and the current chairman of the Society for the Study of Reproduction. And if memory serves, you spent a little bit of time in Sheffield as well, didn't you? Indeed. Right? Yeah, I see. My memory is right. I'll keep those stories to myself then. So, ladies and gentlemen, that is your panel. And what I'd like to do, if I may, is begin with you, Kay. Kay, I wonder if you could take us back to what science and medicine was like in this area in the late 60s, early 70s, when Bob and Patrick were starting their work. If an infertile couple went to the doctor and they said, we're having trouble conceiving, what could science and medicine do at that point?
Well, really very little. I mean, honestly, very little. And this was something that Patrick felt very strongly about because he came from a very large family. He was one of 10 children. And in the things that he's written, he always said that when he saw infertile couples, it was something that he felt very sad for them because really there was very little that could be done. I mean, in those days you could offer donor insemination, but for causes of female infertility, clomiphene to induce ovulation.
Maybe some surgery, tubal surgery perhaps? Tubal surgery
to reverse blocked tubes. So tubal surgery, clomiphene, HCG, occasional injections of Pergonal. But these were really more or less blind treatments. And tubal surgery reversal wasn't that effective in those days.
So not very good for infertile couples in that period of time. No. And I think, in my mind, it didn't really start with Patrick. It started with Bob Edwards. Tell me about Bob and how he started this journey to develop the science behind IVF?
It's funny you should say it didn't start with Patrick, because if Patrick hadn't devised laparoscopy, they wouldn't, you know,
Indeed.
they would never have got off the ground. So in my mind, it wasn't one being ahead of the other. The interesting thing is that they were both working in parallel along completely separate paths. So Patrick was working, he heard about this new technique of laparoscopy that was being developed in Europe in the 1960s. He went to France and to Germany to study with the pioneers, and then he went back to Oldham and he taught himself by practicing in the post-mortem room. And this was in the mid-1960s. Now, Bob, in fact, if you follow his extensive career, he spent actually 18 years between 1950 and 1968 studying reproduction. So he was interested in the whole area of reproduction and genetics. In fact, he was very interested in genetics. And he wrote numerous papers, as you know. But his career took him from, he started in Edinburgh in the Department of Genetics. By the time he left Edinburgh, he had published more than 100 papers in mammalian reproductive physiology and embryology and genetics. So when he had been working, because of his early work in mammalian, in animal studies, he was very, very interested in seeing what he could apply to the human field. He was very interested in the problem of human genetics. And so he started trying to find a source of human material that he could work on. Of course, it wasn't available. He got occasional ovarian biopsies from that he could work on in the lab, but that was his only source of material, either pathology specimens or ovarian biopsies. And he had realized by 1968 that it wasn't good enough. And he happened to read a paper by Patrick in 1968 when Patrick was describing laparoscopy, and it's like a light bulb went on in Bob's head. You know what he was like. And he phoned Patrick and said, "Is this true? Can you really do this?" Because he realized that if he could get freshly ovulated eggs via laparoscopy, then he could study them in the lab. At that point, I don't think his primary concern was treating infertility. His primary goal was understanding what was happening.
So Patrick and Bob had that famous meeting in 1968 at the Royal Society of Medicine. Tell me about that. This
was February 28th, 1968. It was Bob at that time was working in reproductive immunology. He worked in all kinds of different areas associated with reproduction. He was giving a paper at the Royal Society on Reproductive Immunology. And Patrick was in the audience. But at some point, Patrick got up and showed slides that he had taken via the laparoscope of the human pelvis and ovaries with ripe follicles on them. And Bob went up to him at the end of the meeting and he said, "You know, is this real? Can you do this?" And Bob explained what he had in mind, and he was absolutely astonished that Patrick immediately said, "Let's do this." And that's when they started collaborating.
But it wasn't an easy collaboration because no. Patrick was in Oldham. Bob was in Cambridge.
In Cambridge, yes.
No motorways, I would imagine, between the two. So how on earth did they manage to work together with that such
immense difficulty? It was really incredible. I mean, it was at least a 4-hour journey. And so what they did was Patrick would line up laparoscopies. Grace will be able to tell us more about this. Would line up women who were going to have a laparoscopy. And Bob and his assistant, Jean Purdy, would gather together the culture media, the test tubes, and put them in the back of a car and drive up and be there for the time of the laparoscopy. But they had to take all the materials with them. They didn't have a proper lab, they didn't have proper facilities, so it's an extraordinarily difficult collaboration.
But they managed to kind of set up this facility in a small building that was next to the General Hospital, I think, or not far away.
Dr. Kershaw's Hospital.
Yeah. How did that come about?
Oh, that came about, well, they really didn't have adequate facilities at Oldham General Hospital, but they were offered this wee cottage hospital with a cupboard that was basically turned into a lab. But one of the people who was instrumental in making this work was Patrick's theatre sister, Muriel Harris. You remember Muriel, I'm sure, yes. So Muriel took it upon herself to, without any serious source of funding or anything, and with her team of volunteer nurses, to set up a theatre in Dr. Kershaw's. And that's where they started doing the laparoscopies and the egg recoveries. But they were mostly done at antisocial hours, late in the day, because Patrick had a full gynae list. He didn't have access to theatre. They didn't have a way of predicting when was exactly the right time to recover the eggs. So it was all very much hit and miss. And as you know, it took them a full 10 years before they managed to get all the different parameters in place and achieve the miracles that we have with Louise and Alastair.
So you've got a full-time NHS clinician, in Oldham, you've got a full-time academic in Cambridge, and they're doing this out of hours and almost in their spare time with
Absolutely.
The goodwill of the people in the hospital and the people in the lab in Cambridge.
Yes, that's right. I mean, Bob had PhD students, he had lecturing, he had wife and 5 children, 5 daughters, and they were doing this. It's extraordinary. It's really an extraordinary story.
So just before we move on to Grace, just give us a flavour of the kinds of technical challenges Bob and Patrick had to overcome in order to get IVF to work over that 10-year period when they were working together.
Well, every single thing that we now take for granted as part of an IVF cycle, they had to work out from scratch. They had to figure out how to collect eggs. They devised what they called a suction apparatus, a new suction gadget, how to suck them out. They had to figure out what kind of medium the eggs, they had to work out the timing, when to induce ovulation to collect the eggs. They had to figure out how to inseminate them, when to inseminate them, when to check for fertilization, what kind of medium would be required. And then when they eventually managed to get embryos and development, then they had to think about how are they going to put them back. So they had to think about different ways of doing embryo transfer. And even when they managed to start doing embryo transfers, which it was a good 2 years before they started doing that, then they hit on the problem of perhaps the drugs that they were using to stimulate the ovaries was having an adverse effect on the endometrium. So they had to start thinking about maybe they should be supplementing the luteal phase, giving something to help the endometrium. And it wasn't until 1977, in fact, that they had decided to stop using drugs completely. They'd figured out everything else, how to collect the eggs, how to culture the embryos, how to put them back. But this problem of the drugs and the endometrium was one that was very difficult. So they decided to stop using drugs. They were able to do that because a new kit had just become available that allowed them to monitor the LH surge, which would tell them when ovulation was going to take place. So that was what allowed them to start using natural cycles and collect a single egg at whatever time the LH surge happened. And again, completely dependent on this team of volunteer nurses who would work during the night. And Jean Purdy working during the night. And collect one single egg, inseminate it, and put it back without any other drugs. So they didn't start doing this. Louise's mother, Leslie, was the second person that they used this strategy for, so the natural cycle, 1 egg, 1 embryo. And that was in November 1977.
Grace,
yeah.
Can we come to you? Is Kay right about the experience that a patient would have had in the early 70s when they presented to their doctor with infertility? What was the start of your journey like?
For me, I can only talk about myself.
Of course.
To me, it was just a case of it was the only thing that I was able to find that was going to help me. I had looked at loads of different things, and I had also gone through an operation to try and open my tubes, which were blocked, and then I was told positively there's nothing else that we can do. But
so how did you find Patrick and Bob and the Kershaw's Hospital?
I just happened to read about it in a friend who was a doctor had a magazine on a coffee table in their house, and I just opened it, and there was an article about Patrick and Bob, how they were working together. But at that stage, there hadn't been any successes because this was early on in the 70s. But I went to see my gynecologist in Glasgow and said, I've read about this. Have you read about it? No. Would you? I said, I would love it if you would write to them. And he said, right, I'll write if you write as well. So that was really how it started. And we both wrote. We had to wait a while because at that point in time, Patrick was having 2 hip replacements. So we had to.
So his mail was backing up a little bit. Yeah. So which letter did he respond to? Did he respond to your gynecologist's letter or the letter that you wrote him?
Both of us.
Both.
Yes, I got a letter from him to say. Well, it was through Diane Mann, who was his secretary, who said that Patrick was interested, and then I got a letter from Patrick himself to say that he would be willing to see me down in Oldham, and would I come down? So I had to go through preliminary tests and things like that until I eventually said, I want you to come down and we'll do a laparoscopy just to check that everything was all right.
So could you describe what it was like? Because Kay's described a setup that, dare I say, sounds a little homemade. What was the experience like? What was the setup like? How did it feel to you as a patient?
My first impression of going to Kershaw's was, why are all these old people in here? Because it was a cottage hospital, and we were literally sort of cuckoos in the nest, with these, amazing people, because they were so tolerant of us, and of course we weren't allowed to say anything, so I think quite a few of them kind of guessed, oh, there's something going on here, back home, they were lovely, but they never actually directly asked us. But it was a cottage hospital, but everything was, to me, on a cottage scale. As Kay was saying, the theatre was tiny, the lab was a cupboard. And it squeaked, because I always knew when Jeannie was going in at night, you'd hear the door squeak, and she was amazing. Without Jeannie, none of it would have happened. But it was the girls who were all in with me. We became very, very close, and you shared a lot of experiences. Became like family.
So you were actually in as an inpatient. You were staying overnight for several days, and you were in a ward with other women who were joining the programme as well?
Well, on my first attempt, that was in February 1977, I had to go in every morning, or during the day as well, for blood tests, and that was when we were put on the hormone treatment. So I was an outpatient then, but I had come down in December 1976, and Patrick did a laparoscopy. I wasn't, unfortunately. I had become ill again, and I had to have a major operation where he removed an ovary and both my tubes. And but then said on Christmas morning, I've got good news and bad news. The bad news is there's no chance, your tubes are now gone. But the good news is, as soon as you can, I want you to come back down. So I went back down in February and was put on the programme of it was hormone treatment for a few days before they were able to then say, right, you're ready, come in. And once you'd come back, you were in, that was usually maybe just the day before you were ready to go to theatre. So I went in 9:15 on the morning to have the egg removed by laparoscopy, and then unfortunately it didn't work.
So that was your first cycle.
My first attempt.
You had 2 attempts, as I understand it, and you were, correct me if I'm wrong, Kay, you were patient number 247.
Yeah.
And it was attempt cycle number 712, and you were the 87th woman to have an embryo transfer. 97th. Can you describe to us your state of optimism or pessimism about how likely this was to work? Because up until the point of your first cycle, or indeed your second cycle, there had been no live births.
Did you, the second time, did you know about Leslie? Did you know she was pregnant?
Oh yes,
Yeah, you did.
yes.
So you knew there was a pregnancy, but...
I knew there was
Cycle.
for the second cycle, I knew, but the first one, when I went in, I had no idea because we weren't really told. And when I went in the second time, which was on the 18th of May, 1978, of course, I was in with girls who had been in with Leslie before, because some of them came back, well, like one particular friend who, she had actually 10 attempts. And she was in with me in 77 and again in 78. So as soon as I went in, she went, oh, and there's this and there's that and this is happening. And you found
so
out.
I'm getting that there was a sense of optimism in this community of women.
Yeah, there had to be. If you had, I was always, funnily enough, I've always said, positive thinking, you've got to think positively. Because some of the girls I felt came in with a very negative thing. Oh, well, we'll try it, but I don't think it'll work. And I said, well, then it won't. And I think, I don't know if it helped at all, but I think it was something that you had to feel very, very positive about. I don't think you could have gone through it, over and over again if you hadn't felt, well, one time it'll work.
So the question I really want to ask you, and I don't want to cause upset or angst, but the question that's in my mind is that many people have been critical of Bob and Patrick about their modus operandi or their ethical way that they conducted this. And I'm not sure I agree with that, and I've read the papers, but I'd like to hear it from you. How were you treated as a patient? Do you feel you had the right amount of information? Do you feel you were treated with respect and dignity?
Oh, totally. Patrick, I think because there had been quite a few failures, obviously, by this time, he held back slightly, because you could see that it was very upsetting for him to have to go and tell the girls, that it hadn't worked and they were going home. So I think that he used to hold back a little bit, whereas I think Bob was a very, very friendly, approachable, very kind person, and he was usually the one that would come and say, well, he certainly did with me. He came as soon as I think they realised that things were beginning to look good, and he came I was in by that time in a small room on my own, and he came in and he said, I don't want you to get upset because your friends are going home but you're not. So it was, yeah, it could be.
Tell me about Jean. Jean often gets forgotten in this.
Oh, no,
Jean Purdy. Tell me about Jean.
Jeannie was the mainstay for all of the girls. She was like a mother hen. She looked after us all. She would come in again after. As I said, I was right across the corridor from the little lab, and I would hear the door squeak, and she always would stick her head around the door and give me the thumbs up, and I would say, "How are things looking?" She says, "They're looking good." you know. So, and she would always have time for you, and she always just instinctively seemed to know when people needed encouragement, and of course, as I said, some of the girls were distraught because it hadn't worked and they were going home, and it was always Jeannie who would be the person that would talk to them before they would go away and say, now, don't give up, you know you can come back. And But by that time, that was in May and June in 78, Patrick was due for retiral, so they knew that there wasn't going to be another chance. There was one more chance for girls, and in fact some of the girls came back because I was still there. You know, the ones that had been there in May with me came back in June, and after that, of course, Kershaw's closed down, and it was then going to be transferred because Patrick retired to Bourn Hall, which where Kay worked.
I think there's a thought now that Jean Purdy was really the linchpin that held it all together. She was the nurse. She was potentially one of the founding embryologists, but also what we now call a quality manager, I think. Is that the right way to look at it, Kay?
Oh, definitely. I mean, I met Jeannie briefly when I started working at Bourn Hall in 1984, but I got to know her really by looking through all the notebooks that eventually became available after Bob passed away in 2013. So it became very clear, looking at the records, that she was very heavily involved. She was responsible for making the medium. She paid a lot of attention to all the details. She was the one who recorded all the data, and when Bourn Hall opened, of course, she was the one who organised the lab and did what we would now regard as the quality manager's job, and making sure that everything was done exactly right. And we can see the evidence from this. I mean, in Oldham, they had done more than 500 laparoscopies. They had done 112 embryo transfers and had 2 pregnancies. Okay, 2 live births, not 4 pregnancies, 2 live births. And then it closed down completely. They had no lab, they had no facilities, nothing. And 2 years later, when Bourn Hall opened in 1980, it opened in September 28, 1980, they admitted the first cohort of patients, and they did the first 2 embryo transfers in the middle of October, and one of them was pregnant. So, you know, that was remarkable. I mean, that just shows absolutely incredible quality management, quality control. And this was at a time when there still hadn't been another IVF birth in the rest of the world. There were several teams working towards it. But it just shows you the attention to detail that went into that. It was not only Jean, but also, of course, Muriel. And Muriel was responsible for setting up the theatre and all the nursing side. So it's an extraordinary story.
Just one more question to you, Grace, if I may. Did you have to pay anything?
No.
Or was this free?
Only my train fare.
Wonderful. So the question then to you, Kay, is how did Bob and Patrick pay for all this?
Well, with great difficulty. Everything was done on a shoestring. But there was Bob received a phone call out of the blue from an American lady. And Bob thought it was one of his friends pulling his leg, but this American lady phoned from California and said, "I want to support your work." And we now know, she wanted to be anonymous at the time, but we now know that her Linian Lincoln Howells was her name. And she was responsible for giving them the funds that allowed them. I mean, Patrick and the nurses were supported by Oldham General Hospital, although they were doing a lot of work out of hours. And Bob, of course, has his Cambridge University salary, and Jean had her salary. But the extra funds that were required were basically due to the generosity of this American philanthropist lady.
Incredible. Alastair, thank you for coming. You must have heard a lot of that before from your mum growing up. It must be part of your kind of family story. Is that true?
Yeah, I guess it is, although it tends to more come out at events like this, yeah. Things like that. But every time I learn something extra, which is quite fascinating, really, I suppose. And with my mum, she's getting on a bit, so it's good that her brain's still working.
No, she's not. So tell me, I think the question that's going to be on most people's minds is, when you were growing up, how was it growing up as the world's first IVF boy and the second IVF baby?
Normal. I've never really known any different, to be honest. So, I mean, in the sense of growing up knowing that, I think it's only ever really been when friends have brought it up, just to say it's been that. In fact, most of my friends are always dying to tell other people that this is Alastair. He's the world's second test tube baby. I was like, keep it quiet, thing. But I mean, I suppose perfectly normal, but very proud at the same time. Yeah. You know, it's I mean, to actually grow up knowing like Bob and Patrick. Unfortunately, I mean, I'm too young to really remember Jeannie, unfortunately. But before we lost Jeannie, but it was like knowing that I knew those very important people in history is actually quite a proud like feeling to me, to be honest, and something I guess I'm very proud in some ways to be some form of ambassador for them. So, yeah.
You told me when we chatted on the telephone last week, you told me about the story when you first found out that you were the first IVF boy and the second IVF baby. How did you find out?
So, well, it was quite a sad time at the time. It was when Patrick had sadly passed away in 1988, I think it was now. But I mean, we did know, but my mum told me. I think you managed to find out before the news did and things. But it was on the news as well at the same time that Patrick had died, and I thought, why is Uncle Patrick on the news as well? I knew he died, and then they brought Louise Brown on as well. And said, why is my friend Louise on the news as well? It was quite a coincidence, and I thought, wait a minute, am I a test tube baby? And I said, so I went running to my mum and I said, Mum, now I know why I'm special. I was a test tube baby. She said, yeah. So I mean, yeah, it was quite surreal, really.
I can imagine. So, I want to ask you, Mum, actually, if you could pass the microphone back. Why didn't you tell him sooner?
I didn't want him to grow up feeling any different. You know, to me, he wasn't different. I mean, maybe just one little part of him coming into the world was different, but as a little boy, he was just the same. And he went through the terrible twos like all like other kids. So why tell him that he should be any different? I didn't see the point in that. And also I wanted, at that stage, nobody really around where we lived knew. So.
How much were you influenced by the publicity that Leslie Brown had? Because she'd really been put in the media spotlight. Did that influence your thinking at all?
Very much so. Leslie and John and Louise actually came up and stayed with us when Alastair was only he was premature. It's the one and only time he was on time in his life. No, he came early. He was a month early, and they came up and stayed. And Leslie was amazing to tell me, avoid this and watch this, because she said she felt she had been deprived of having that, that special time with Louise when she was very small. So it just made me realise, no, I'm not going to lose this. So that was they were, as I said, John and Leslie were fantastic and stayed very close friends, until they both passed away.
Alastair, you said for a moment ago that you felt like a bit of an ambassador, and that I sense that you wear this now with pride. Have you got any memories of Bob or Patrick that are distinctive in your mind that you hold on to?
Okay, can I just interrupt?
You can.
I want to point out that Alastair wrote an amazingly eloquent letter to the royal family, asking that Bob should receive a knighthood.
And I got it.
You did get it.
You didn't get it? No, it was a really nice letter. I remember. I don't remember exactly what year it was, but I remember, and it went to the
Can you
wherever it was supposed to go in Buckingham Palace.
Can you remember what you said, Alastair, in that letter?
Oh God, I'm trying to remember now. Yeah, but pretty much in no uncertain terms can you make Bob a sir. But yeah. I don't. Yeah, well, I remember saying and he had been recognised. He did have his CBE, but I did get that kind of wrong at the time. I said at that time I thought he hadn't been recognised, and I thought it was like. But I did like say that you see so many people who are sports stars. I think who, don't get me wrong, deservedly do deserve that kind of recognition for what they do for their sport and things like that. But I thought. I mean, this person's given 5 million babies around the world that haven't been here. I say, why has he not been knighted and things that would be... well, I worded it a bit differently. but I said, like, he would... Yeah, surely he should be recognised in some form. And then other people have been... I did say as well, other people who've worked off his... I'll not name any names, but certainly other people who have worked off his work have been had been honoured before. Honoured before, yeah.
Indeed.
So that, yeah, that's
I think many people think it took far too long for him to get that honour. And I think I'm very pleased that you did that. Your mum told me on the phone when I spoke to her last week that Bob was quite an inspirational figure in your life, and was someone that you looked up to. And if I may, I just wanted to say that I think knowing Bob as I did, not as well as Kay, but I did know him a little bit, I think he would be immensely proud of you, and he would be proud of you coming here tonight and sharing your story to an audience like this.
Oh, bless you. Thank you very much.
Bob was always very proud of Alastair. He was great with you, wasn't he?
Yeah, we had quite a good rapport.
We had an excellent rapport. He was always telling jokes and laughing.
Thank you. Can I move on to Abha, if I may? Abha, you're in charge of a busy IVF unit in Aberdeen, and don't panic, but I looked at your HFEA inspection report last night. And the point that I'm going to make is that last year you did 951 treatment cycles in 1 year. Put that into context of what Bob and Patrick did over those 10 years. So the point I'm making is that IVF is now a standard, reliable technique that is widely used around the world. But Abha, could you tell us through modern eyes now how it's changed? What is IVF today like?
Well, IVF today is slightly different from what it was at that time. So we start with similar sort of things like stimulating a woman's ovaries using hormones, and they inject the hormones not just for 2-3 days, but it is about for 10 to 12 days at least. They get monitored with ultrasound. At that time, ultrasound wasn't there, and ultrasound was a great invention. So we monitor them with transvaginal ultrasound. They need to have 4 or 5 ultrasounds. And once we find that the eggs are ready, we give them final booster injection and collect the eggs. So that means that we can time when we collect the eggs, not out of hours or in night and everything. So it's all timed and well, kind of, we say controlled. We get multiple eggs rather than just 1 egg. With multiple eggs, they get mixed with sperm, either just by putting them together or injecting sperm into the egg, which is ICSI. They then get grown in the lab in culture media for 3 days, and now actually lately we are growing them up to 5 days and sometimes up to 6 days. What that does is we are able to select the best embryos, because as they are growing in the culture, the ones who are not right don't grow to the next stage. This allows us to select the best embryo, then we transfer the embryo, and again we do it under ultrasound guidance so we can see where it is being placed. So all that advanced, we don't have to do laparoscopy or poke needles in the tummy. We can do the egg collection using the transvaginal ultrasound and with the needle, which is much quicker process and much simpler and safer process. Also, after transferring the best embryo, we've got other spare embryos which are very good. We can freeze them, and technologies have advanced so much that whatever goes in the freezer almost comes back as it is. So women can come back without having to inject the hormones, without needing to go through the process of egg collection, to have either second baby if the first time it was successful, or to have the second babies or if this wasn't successful, to have another treatment without needing to go through all the saga. And we can treat people very quickly. Over the years, the stimulation regimes, the injections that we give, they have become simpler as well. We used to use injections, and the whole process used to take 3 months. Now we can do it in 2-3 weeks. So that has become simpler as well.
And what's the likely chance of success there?
We're talking about success depends upon mostly the age of the woman, and we are talking about roughly about 30%. So 1 in 3 embryo transfers do give to live birth, but younger you are, the higher the chances are, and can go up to 40-45% if you are in early 30s.
And in terms of getting access to IVF, I mean, there must be an IVF centre in every major city now, if not more than one.
Yeah.
How is that? Because we do read in the press often that this is an area that isn't well funded by the NHS and people have to often pay privately. What is that scene like?
Well, you are sitting in Scotland right now, which is not the case.
So tell us about the situation in Scotland.
So Scotland is one of the few places where a full entitlement or recommendation of NICE guidelines has followed. So NICE is the body that produces the guidance for the United Kingdom, and they recommended in their wisdom that we should have 3 cycles of IVF funded for everybody who is entitled for it. And 1 cycle for them includes an egg collection and all the embryos created from it. So the hope was that after 3 cycles, actually what we call as cumulative pregnancy rate or cumulative live birth rate can go up to 50%, because once you add all the cycles together. Scotland, we have got full funding, that is all egg collection as well as all the embryo transfer, fresh and frozen, are included in it. Whereas in England, depends upon which CCG you belong to. So there are as many CCG and as many permutation combinations. So you could have alone fresh funded, you could have very few of them fund all 3 cycles. Some only fund 1 fresh cycle, some only fund 2 embryo transfer, which could be 2 fresh embryo transfer or 1 fresh or 1 frozen, irrespective of age. Some have the criteria for body mass index for even male partners, and some have some blood criteria where they don't fund above that. So there are as many criteria as you can think of.
We look very enviously north of the border from England sometimes at the provision and funding that you have in Scotland. It is very difficult in England, and very hit and miss as well. I don't really understand it half the time. IVF is the success rates are largely dependent upon women's age, as you said, but there is always a desire, I think, for improving that and for incremental growths in success, and that's led to the development of a whole range of things: assisted hatching, use of ionophores, embryo glue, reproductive immunology, IMSI. What do we make of all this stuff that kind of now is around IVF?
So Yes, what we are doing here is an IVF, putting egg and sperm as close together, putting them back in woman's womb at the right time, supplementing that with hormones. So there is an assumption that why it should be, success rate should be anything less than 100%. But as we say, we are far from 100%. It's only a 40-year-old treatment. So we need to improve the success rate. Hence, all these things were brought in the picture. And people have tried through the basic science research and other research, tried various things to improve the success rate. However, most of them, when they were put to the test of randomized controlled trials, have not proven to show the benefit, the ones you have mentioned so far. Some things have shown the improvement, like using the ultrasound for embryo transfer has shown there is an improvement in the success rate, and that has been put in the practice, whereas others, such as IMSI, hasn't shown the improvement. But there is need for continued research because we need to improve the outcomes, not just getting people pregnant, but we are now looking at long-term health of the babies, and we want to have more healthier babies, not just have babies, healthier babies, because we are living longer and we want to give the next generation a healthier generation. That's what.
Thank you. The reason I asked that question of you was because Sally Cheshire, the chair of the HVA, is next, and I want to move on to Sally, if I may. Sally, you have a very important job in the HFEA in regulating all of this. Have we got it right?
That's a very big question. Have we got it right? I think just to touch on success rates, then they're now double what they were in 1991 when the HFEA came into existence. So Abha's right, we see improvements year on year. Natural conception is notoriously unreliable. So it isn't ever the case that people are going to be 100% successful. But we know that anything we can do to try and improve those rates is the right thing, whilst at the same time making sure that women aren't put at excess risk when they're pregnant or when they're trying to become pregnant, that babies are born as healthy as possible, that clinics adhere to all the right standards, and that generally we have got it right. So life isn't perfect, but the HFEA was the first regulator in the world, and is still respected, as is the fertility sector. And as Abha said, we've had a lot of productive meetings today where we've discussed with the Scottish clinics what they do, how they do it, how they're working on improvement, what the funding situation is. And in the rest of the UK, there are lots of people who would say, I wish we were in Scotland. So actually, we've had a very productive meeting today. We're thinking about how we can actively improve success rates, standards in clinic, using the huge amount of data that we have. There have now been over 1.1 million cycles of treatment that people like Grace were brave enough to start all those years ago. So we have data from over 1 million treatment cycles, of which around 1 in 3 are successful. And we need to use that data more and continue research to make sure that the success rates that we have go up. They continue to go up. What's really important for me, though, and many people will know that I was actually a patient and the only chair of the HFEA who's ever been a patient. So I do a professional job, but I absolutely know how it is to be in a clinic and to go through that devastation of being told that you might never have a child. And what we want to do, within the confines of our law, is make sure that we are caring for patients all the way through. And actually what we talked about today in Scotland suggests there's a really good level of care. We are trying to reduce multiple birth rates, and actually every single clinic in Scotland has met our target. So well done to Abha and all her colleagues in the audience, because you are doing a very good job. In terms of add-on treatments that you touched on, I don't know whether you're going to come back to that.
Carry on.
Because currently we see an increased incidence of optional extras on top of the basic IVF procedure that Abha described. And what we'd really like to see is that every single clinic does basic IVF really well, and that every patient has a really good experience. So actually, some of the things we ask now are exactly what Grace talked about before when you asked, are you treated with dignity and respect? Is your privacy respected? Do you receive good emotional care and support from all of the people around you in a clinic, whoever they may be? And when you have a busy clinic that does 1,000 cycles a year, is that clinic and all its staff still providing that fantastic care that you got when you were really special in a small cohort to every single person who has to go through fertility treatment? And I think in many senses we have got it right. So I'm really heartened to know that you read HFEA inspection reports. But actually they are very valuable and clinics take them very seriously. And the satisfaction rate of people who now have treatment is that over 3/4 towards 80% of patients, even if 2 in 3 of them don't get the family they want, are very satisfied with the treatment that they received. And I think if you went back, although you were very cared for, I think that hasn't always been the case as IVF has expanded exponentially. And we're back in an era now where the HFEA aren't just concerned about success rates, but partly because of my experience and my colleagues and people here in the audience and some of the bodies that we work with across the sector are also really concerned about the level of care that we provide. And if we can continue to combine increasing success rates, perhaps a little faster than we are, but at least at the rate that we are, and having healthier babies, mothers at less risk, and people feeling that they've tried their best and they've had the best care possible, then we have got it right, haven't we? There are very few branches of medicine where funding is such an issue, because the rest of the UK isn't in the same place as Scotland, fortunately, is. There are very few areas of medicine where that funding situation exists, where you have to put your own money into paying for something that can be one of the defining moments of your life. And if you feel that you've been cared for along the way, then, you know, we are doing our job. And the regulatory is only part of a very vibrant sector where generally, despite the outcomes, people are happy with the care that they receive. What we need to do, to come back to add-on treatments, is make sure that patients aren't exploited in any way or offered things that potentially may work in the future, but currently that there is no evidence to support the fact that they do work. And actually part of the discussion today is that if you receive treatment in a Scottish clinic, by and large, you are receiving basic IVF treatment done very well, and there aren't quirky add-ons at the moment that you are being required to pay for. So I say, well done, Scotland. And if the rest of the UK was like you, we would generally be incredibly happy.
Thank you, well done. It's amazing what you do find out in HFA inspection reports, and I do read them quite frequently, actually, and it's very interesting. I'm going to ask you a question now, if I may, that I've asked 2 previous HFEA chairs. I didn't warn you about. So I've asked this question of Ruth Deach, and I asked it of Lisa Jardine as well, and I don't think there's a right or wrong answer, but I'm simply interested in your view. If Steptoe and Edwards were starting their research again today, do you think we would let them carry on?
Well, it's interesting because there are parallels today. There are people doing innovative/maverick research in this sector and in others. There are more ethical safeguards these days. I'm not sure I know the answer, because we're in a different era, aren't we?
We are.
We're in a completely different era. You know, but if you ask the question 5 years ago...
I'm not saying this because I think they were doing anything bad.
No.
But I'm just, as an academic, wondering if we would ever have the bravery or the determination to do what they did to get as far as they did. So my prism is not one of, no. I think they were doing things bad. It's about us as a society. Are we brave anymore, do you think, in our research?
I think there are probably researchers here, aren't there, who would argue that they were brave. And I know Colin's going to come on to some of those people, exactly. But if you think back 2 years, 5 years, you know, would we have done genome editing? Would we be treating patients who have mitochondrial disease? would we be screening for genetic disease, of which we now permit clinics to screen patients for about 400 conditions. So actually the world moves on all the time. And I think your question needs to be answered slightly differently. So perhaps if Patrick and Bob and Jean and Muriel and all of the people who made this work were here today, they probably wouldn't be allowed to do exactly what they did then, because there would be ethical safeguards around it. But actually, we're now approaching new questions, like mitochondrial donation, which, for those of you who are familiar with the debate, we approved for licence in treatment, but it goes back 10, 15, 20 years, you know, from the people who first tried to pioneer it, and Newcastle isn't that far away, who have worked on it for decades, actually, before it was ever allowed in research and was successful, because it took a long time to be successful, just as IVF treatment did. But, you know, where will we be in 5 or 10 years' time? The interesting point for me is how we approach it in the UK isn't how it's approached in the rest of the world. And you, as a UK resident, will ask that kind of question and we'll debate it at a pet event, and we will take very seriously the ethical safeguards around new treatments. But that isn't always the case in the rest of the world. And there are two things to that. It's a very positive view of the UK and how we take seriously all of the scientific and research developments that come into practice. But there's a question for the future which Colin might come to, which is will the UK actually get left behind? Which I feel quite strongly about. We've pioneered all of this research from the earliest days of Grace and Leslie Brown having treatment. We are very clear about our jurisdiction and what we will allow and wider research. And I don't want it to be different, really, in the rest of the world. And I'm sure Ruth Deitch and Lisa Jardine would say exactly the same thing. You know, we agree on many things about doing the right thing. But that's not always the case in the rest of the world.
Thank you. That was actually going to be my last question to Colin, but it's fine, it's fine. Colin, if we could turn to you. I want to ask you, you are a doctor, researcher, you're the current chair of the SRF. Have we solved all the problems, or is there more that we could solve and work on? What's going on in this field?
When I see a patient in the clinic for the first time, I always say exactly the same thing. And what I say to them is, I say, if you take a fertile couple from Edinburgh and you lock them in the room for a month and you say, try to make a pregnancy, and there's no issues at all with their fertility, they're totally normally fertile. At the end of that month, when you open the door and check to see whether a pregnancy had happened, if they're still talking to one another, what happens is the chance of that is 22%. I always say that is the natural fertility of human beings. A couple of rabbits in the room, pretty much guarantee it's going to happen. But human beings, every month, it's somewhere between a 1 in 4 and 1 in 5 chance of achieving a pregnancy. And what I say is that what we do in the clinic is we say, is there something that's changing that chance? What are the chances? And what can we do to make it closer to that 1 in 4 or 5? And what you've heard is, in the past, we couldn't return it to that 1 in 4 or 5. But now, IVF does return it to that 1 in 4 or 5. We can return fertility to normal. The problem is that people want to return fertility to more than normal, because you don't want to go through this multiple times like the woman that you were talking about earlier on, who was on her 10th attempt. So I think that what we really want to do is change nature in a little way and sort of try to improve on it. And I think that's going to be very hard to do. And I think that what happens is that there's been huge, big advances. And you were talking about freezing. And I think freezing has made a huge difference in IVF. And we're looking ahead to think, are there other big advances that are going to come? But I think that what we're going to see now on is little chips away. I don't think there's going to be huge, big, major advances anytime soon. I think it's going to be little chips away. And these chips away are going to be around, is there ways that we can really improve the selection of embryos? That might be important, maybe less important when you've got a really good freezing program, but can we choose the best embryos to put back? Can we make sure that the lining of the womb is absolutely in tip-top place for those embryos? Are we doing best practice? Are we doing what we really should be doing? And are we maybe being person-centred in personalised medicine? Are we personalising the treatment which is optimal to that person? And the more we get right at that, we'll get small incremental changes. But I think that there are big problems. When I see somebody in the clinic, there are lots of different people that we struggle to do things about. And the things that we do are people who've got lack of gametes. Women who've run out of eggs, women with a small number of eggs, women who are getting older, men with no sperm. And I think these are the patients that we really, really struggle with, and particularly women with a small number of eggs, or who achieve a smaller number of eggs. And I think that's the thing that causes me most heartache when I'm speaking to patients in the clinic, and that's the sort of thing that I think that is probably the priorities for sort of looking towards things. Are there ways we can get older eggs to have more energy so they don't make a mistake when they do these final divisions? Are there ways that we can create good eggs in the laboratory from stem cells that aren't an egg in the first place? And there's some pioneering research going on. Very early days, can we do that? Can we get an egg from its very, very immature stages and grow it into an egg that's fertilisable and an egg that can be put back? And there's some really pioneering research, world-leading research happening in Edinburgh, about that. Because when I've got a woman who I say, look, you've not got very many eggs left, and if we did IVF, we might just get 1 or 2 eggs out of that, then she's got 100,000 eggs in her ovary. It's just we can't get access to them. And if we can, maybe we can choose eggs, maybe there's an ability to do that. And there is research, and I think these are priorities for research, because we're quite good at treating people who've got a very sort of clear reason. There's an issue with sort of the tubes, an issue with that. We're never going to get 100%, but we're good at doing it. We return fertility to better than normal. But what we can't do are the very challenging patients that bring the success rate down, and often these patients are very, very desperate. And they may well be they're in their 20s with a very small number of eggs. And I think that these are challenges that people are working on, and I think these are the challenges we need to look forward to.
So I've just realised that in my list here, it's really the things I was going to ask you about are all of the things that are not there to increase the success of IVF, as you quite rightly say, but opening the access to it. So uterine transplantation, for example, we can get around that through surrogacy, but it might give a woman the opportunity to get pregnant naturally. Lab-made sperm and eggs. Fertility preservation is giving somebody who goes through a cancer treatment an opportunity that they might not already have.
Well, one of the big talking points, and it's very interesting, and maybe there'll be some questions about it later on, it's about the ageing egg. Because what we know is that's often the most challenging time that particularly in today's society, women are putting off having a pregnancy. And therefore, what we're seeing people in their late 30s, early 40s coming to the fertility clinic. And one thing that IVF is not good at is treating age-related fertility decline. That's one thing it can't do. And so the big question is about whether or not women freeze their eggs when there's lots of them and they're young eggs. And social egg freezing is something that is becoming more and more thought about and common about. Yes, we can freeze eggs in people who are going to undergo cancer treatment that might affect their ability to grow eggs in the future, but actually the whole question, and there's a lot of debate, and I'm sure you've read a lot about it, in the newspapers and the lay press, with regards to whether or not that's a good idea and what should we do. We're not at the stage where it makes an awful lot of guarantees, because you have to store a lot of eggs to guarantee a baby, because we're turning fertility back to normal, but fertility is back to normal is not much better than that 1 in 3 with the IVF, which you said. So you have to store a lot of eggs to guarantee that. But it's something that people are having to think about, and that's obviously one of the things that is progress, and is that going to make a difference in the future? And I don't know.
So could you finally answer Sally's question, which is her concern and my concern, because I wrote it down here. Do you think that the UK is potentially going to be left behind with some of these developments?
Well, I think when it comes down to reproductive science, I think that there's some serious things to say. The first thing about it is that Britain still punches above its weight. So if you look at reproductive science in the UK, it's still punching above its weight. Scotland punches well above its weight. And if you actually look per population, Scotland is way higher than anywhere else with regards to publication in reproductive science. And I think reproductive science is I think the biggest challenges to reproductive science are not Britain being left behind, it's the whole funding environment for that type of research. And throughout the world, that type of research isn't necessarily being prioritised by public bodies, because there is a feeling that we've got IVF, there is a fertility treatment, why do we need to do something more? And so it's very challenging when you've got, lots of money to say, how we should be prioritise what we give to research to. And people will say, well, of course, there's cancer and there's heart disease and there's strokes, and all these things are phenomenally important. And there's big charities that are giving lots of money into these research, as well as the public body. But there's not a lot of big charities that are giving, in fact, I don't can think of anyone that will give money for research into fundamental reproductive science. And therefore, I think that the way we're going to be left behind isn't because of the HFEA's stance in research, it's not because, there isn't the talent there to do it, it's because of the challenging funding situations. And I think that these things are always going to be the case, and we're going to have to argue our corner, and in order to sort of make sure that the public agree that what we're doing is actually sort of worth investing in.
My son works for a company called Natural Cycles, some of you may know of, which has developed an app for your phone which monitors your daily temperature, with the idea that it therefore monitors your fertile period in a given month. At the moment, this is being marketed as an aid to contraception. Success rates are comparable with natural methods, apparently. They are also working on developing it as an aid to predicting fertility for conception, for those who want that rather than the other. But I don't think that's gone very far as yet. The main market seems to be for contraception. Does anyone on the panel think that this would be a useful contribution to women with fertility problems?
Is that based on temperature, did you say?
Yes, daily temperature monitoring.
Daily temperature. That's
been around for a long time, Kay.
Oh my goodness, that's really amazing, because I have to tell you that when I started, well, you know this, Grace, don't you? All of the patients in the 1970s and the early 1980s, what they had to do for months and months and months was measure their basal body temperature every morning. And this is how we decided on what day of the cycle they were likely to ovulate, and based on 3 months worth of temperature charts, at least 3 months, some of them had years of temperature charts. Based on that data, we would suggest, well, you have to come in on this day because you're likely to ovulate 3 or 4 days later. And that was what we used to gauge when ovulation was likely to take place. But it's been used for for contraception for years and years as well. It was also so, but it's not infallible.
No, I'm aware of the fact that this is old technology. The convenience of this particular thing is that the app includes an algorithm which analyses your data for you and gives you a readout. It also feeds back to the parent company so that they have data from, I forget how many, I think it's 25,000 users or something of that order. And it's a sort of voluntary clinical trial, if you like.
Colin, is our app-based things going to revolutionise our life? Because these things are amazing.
Well, I think that app-based things will revolutionise our life, and I think that some doctors will have to learn how to use apps or become apps even. but actually, when I see a patient or a couple in the fertility clinic, and I'll say, well, when was your last period? And they'll say, I've got an app for that. And so I don't think I've ever met a patient who doesn't have an app that tells them about lots of these things. I think that when it comes down to looking for the fertile time, I think that it's straightforward when somebody's got a very predictable cycle, and you can really work that out by doing some very simple counting. Patients are very keen to determine whether or not they're releasing egg or not, and temperature-based monitoring can do that. And a lot of patients like the fact that they get some temperature. Sometimes they worry about it because the temperature doesn't quite do what they're expecting it to do. And the other thing about it is when your temperature goes up, your fertile time is over. and therefore your fertile time is before your temperature goes up. Because temperature is increased by progesterone, and progesterone happens, just post-ovulation. And progesterone does several things, but the one thing it does is makes the cervical mucus, which needs to open up to let the sperm swim through, very thick, and therefore the sperm can't get in. So once your temperature goes up, that tends to imply that the fertile time's over. But over time, in analysing cycles, it'll give you very clear timing as to when to do that. But the crucial thing about it is that often you manage to do that with timing. And the more information patients get, the more they worry that their temperature hasn't quite gone up to the same level as it should do. And it sometimes can actually cause some anxiety. And I tend to say to the patients, don't monitor your urine for surges and things like that. Just sort of, if you're wanting to make extra effort at the fertile time, maybe do some counting.
And you sounded to me like you were encouraging young women to freeze their eggs. Very close to it. And I just wondered if that's true, and also what the other panel, what Grace and your son think of that young women should not be leaving this to their late 30s and 40s, and also where we're at in terms of the debate about the 10-year limits. Is that something that the HFEA are actively talking about, reflecting the debate, as you said?
So let's start with you, Colin.
Well, I've never advised somebody to freeze their eggs, because I think you have to freeze an awful lot of eggs and go through a lot of cycles to guarantee pregnancy, and then it can become a false sense of security. And my advice is always to try for a pregnancy when you're younger, but that sometimes isn't very possible. The reason I was talking about it is because with regards to treatment for aged aged oocytes or aged eggs, we don't have anything. And if you're running out of eggs, we can't do anything apart from using a donor egg. The only thing we can do is if somebody had stored eggs earlier on. That happens to be really the only treatment we have. Now, whether or not that's the right thing to do, whether the NHS should fund that or not, these are things for public debate. But it's certainly something that I've not been recommending to do. But it is something that people are thinking about, and therefore we have to talk about it.
Grace, do you have any thoughts on these changing social attitudes towards freezing eggs in younger life for women?
I wish I'd had the chance, actually. Of course, there was nothing like that at all available. I think from the point of view of it being a fallback for someone, but I don't think I would want it as a first avenue to go down. I think just what Colin was saying is to try when you're younger, because I think there's obviously the eggs are probably better quality as well, and I don't know.
It's a social challenge,
It's a social
challenge. Abha, do you have any comments?
Hi, I would like to just echo what Colin and Kay have said, is that we are not encouraging anybody to freeze eggs any younger, because we don't know whether you'll have difficulty in conceiving or not. Most infertility or difficulty in conceiving is only 1 in 7. So 6 out of 7 people will not have difficulty in conceiving. And what we forget, IVF is becoming simpler, but it is invasive, and you have to go through injection. There is still associated risk of what is called as ovarian hyperstimulation, which can put you at risk, and there could be long-term implications. And we know that there are high risks associated with every procedure, and what we are doing is artificial, and we still feel that nature is the best, and we can't beat the nature. So,
Sally, the law says that you can keep your eggs frozen for social reasons for 10 years.
It does.
Should that be changed, do you think?
But if you have a diagnosis of infertility, you can store your eggs for 55
Indeed.
years. And the issue is actually around the inequality in that decision potentially, rather than advocating that women freeze their eggs. I agree with everything that Colin, Abha and Grace have said. It wouldn't be a first avenue. It's not the responsibility of the HFEA to say whether women should be freezing their eggs. So I don't think any of us on the panel are recommending it as a choice. But if the law were to come into line, then we would support a move to change that. It's actually a very complex question, and we have just produced a report around egg freezing from the HFEA's point of view in terms of statistics, a number of women coming forward, and trends, and we will repeat that. So I think this is a slightly slower burn. Sarah might want to comment about social egg freezing, but we need to make people aware of both trying when you're younger if you can, making sure that you use it if you want to, but the younger you are, ironically, the less likely you are to use the eggs. Because if you're trying to get pregnant earlier and you've already thought about that at an early age and you've frozen your eggs, you're perhaps more likely to be successful without ever having to use those. And there is an invasive procedure. It's a very emotional journey. You are going on the emotional roller coaster of having an IVF cycle, and probably there's no funding for you, so you need that, and you probably have to pay to store those eggs for potentially a long time. So I think it's a personal decision. It's a very complex one. If there is a change in the law isn't going to be changed wholesale, but there may well be regulations that could add to the legislation that's in place that might make that change. But I don't think we're at that point right now.
My recollection of that report, correct me if I'm wrong, is that more women are now doing it than they were, but they weren't necessarily coming back to use the eggs. Is that
exactly?
Yeah.
Because a lot of that storage of eggs is quite recent, and you can store them for 10 years, and we haven't reached that period. And still the numbers are very small. And the numbers are even smaller who come back to thaw those eggs and use them. So in future years, it will become more interesting, and we aim to kind of keep people informed.
Question there.
I just want to come back to the lady's comment before. I'm a therapist, and we use Fertility Friend. We use temperature charting. It shows us a lot about when people are ovulating and what their hormones are doing. Myself, I'm a reflexologist with additional training with Barbara Scott. And we look very closely at how the cycles are, and looking at cervical mucus and things like that. So we get a lot of information out, but there is already apps out there that are very good. So yeah, we've seen it work. In fact, we've just had quite a few positive pregnancy tests for this year.
And there's even an app out there to test your sperm now.
That would be handy.
You can clip a little
because
thing
we
to the
often
camera.
have to get the men on board as well, because the sperm, as we know, is starting to have the issues. Well, not starting, but we know there's an issue.
Some people say.
Yeah.
Alison, I'm not a fan of that argument. I said I'd keep my things to myself. Alison.
Yeah, thanks everybody for your input tonight. It's a fascinating journey, and unfortunately I've been around for quite a lot of it. But one question I do have for, I think, probably Sally, and that is, we're 40 years down the line. You've spent time with us in Scotland this afternoon, and impressed that we've got 3 cycles for so many of our patients. Why can't we have that throughout the country, and how can we change that? Because obviously we've done all this research. Grace has spent her life trying to achieve pregnancy and having Alastair. But there's so many women still denied IVF that need it through a funding issue. And that impacts on research as well, because so much of the IVF treatment is done in private centres in England. They're less inclined to be involved in research, and you can correct me if I'm wrong there. So it's a double whammy. People aren't getting the treatment they need, and we're not getting the research input we need. So how can we address that and make people fund treatment?
Gosh.
If only we had all night. Indeed, why can't we have the same level of treatment, of equity of access in the rest of the UK? Something I ask myself every day. It's driven largely by the commissioning system in the different countries, and also a slight level of fragmentation, particularly in England. So the majority of cycles still take place in England, where the funding situation is quite difficult. And I know there will be lots of people in the audience who have a view about that. Scotland is different because it took policy political funding decisions in a different way. So it isn't anything about the quality of care in clinics, it isn't anything about clinicians like Colin and Abha wanting to do anything differently. It's a policy and funding question. And in effect, as we discussed today, in the 4 home nations, there are different policies, really. And actually in Scotland, you are fortunate to have the best. It may not be perfect, but it is the best. We don't have any powers of regulation around commissioning or price or all of the really difficult issues that exist in IVF today, apart from research. But I do think we're trying to do our best. And the sector in Scotland could really show the way. You can slightly embarrass others into doing something differently. But the last part of your question was about how can we make it different. We can't make it different. It's about the will of politicians to have a policy and a funding regime which supports that. And you will know that all health services are pretty cash-strapped at the moment. I get very frustrated when I see that IVF is easy to cut. It's easier to cut IVF than it is to cut treatment for heart disease or children's cancer or anything that's incredibly emotive, without people realising that having a baby or not is probably one of the most emotive and difficult decisions that you will ever have to make, and that it isn't a lifestyle choice. For most people, it's a disease. It's something that you have that you can't correct. So if there is anything that any of us can do around trying to change that situation, I'm absolutely sure that we can. But for now, you need to thank your lucky stars that you're working in Scotland. And, we have to hope that the rest of the country will follow suit. We are doing some work around pricing and around providing some guidance to commissioners. So Abha's right. It's largely about where you live and what the local policy is, because in England, policy and funding decisions are devolved to a local area, which means we don't have the national systems around commissioning that we used to have, and they didn't work perfectly then. They work even less well now. So you are subject to that local decision, and it's about trying to make the best. And there are patient charities, there is PET, there is us, there are people who work across the sector and the professional bodies who do try to put the view across that says don't cut it just because it's easy, but actually think about the impact. I read about one the other day. Actually, there was a consultation where was it 80% of the people voted to keep, it was in Oldham actually, so there was a lot of news about Oldham being the home of IVF, but they've cut their funding to 1 cycle. And I'm actually from Manchester. Manchester has upheld more cycles than most other places in the country for a very long time. But the kind of dismay that even Oldham, where it all started, are cutting their funding, and I think it was 80% of people who opposed the decision during the public consultation, and they still went ahead and did it.
Consultations are never a good idea. Abha.
Thank you, Sally. We completely appreciate that HFA don't have the power to enforce the NICE guidelines, but I would like to echo what Alison said. What view politicians are probably taking, or whosoever is cutting the funding for IVF, is a very short-term view. They only see fertility and the live birth rate. But what they're not seeing is that fair enough, fertility treatment is self-funded by a high proportion, especially in England. But antenatal care and the pregnancy care and all the complications of pregnancy are all being dealt within the NHS. So there are examples from Scandinavian countries and now from Scotland as well, that if you provide the funding well, then you can cut down the complications such as multiple pregnancy rate, which cut down the cost on NHS of neonatal unit and other, and that you can fund back into funding better IVF, and that has reduced the kind of complication rate for various IVF treatments as well. In addition, that, as Alison says, get into research as well so that we can provide the evidence which gives you right treatment rather than multiple add-on, and there are people who are paying thousands and thousands for IVF which don't need to be paid for that. So it is a very short-term view. There was also a paper from Sheffield, where Allan comes from, about from Professor Bill Ledger, that IVF is actually, funding IVF is good for future economy, and there is a proper health economics analysis for that.
Healthy babies pay taxes eventually.
Absolutely.
It's a good thing. There's a question here.
Hi there. There's been a couple of comments tonight about multiple births, and I was just wondering if you could just explain a bit more about the stats and the situation of that and controlling it, and what maybe the ethics might be behind that, and then also, I guess, along with that, choosing the best embryo. Obviously, there's going to be kind of scientific parameters, but then where's the limit currently?
So, one of the biggest complications for IVF was multiple births when it started. So when it started, the first baby and the second baby were singleton babies, and used to put one embryo there. But then when people started doing more IVF, they used to think, well, we will put more embryos back, then probably we'll get better success rate. Once the HFEA data was available, then there was a paper published, which was Sentinel paper, from the Scottish professor, so, which showed overnight that if you put 3 embryos back versus if you put 2 embryos back, there is no increase in the success rate, but you reduce the triplet rates significantly. So overnight practice did get changed. It took us a long time to change from 2 to 1. So HFEA have done a tremendous job with their one at a time program, and they put the target down from 20% to 10%, and we are nearly reaching the target across the country, and in Scotland it's about 5%. Few things have made it happen. A, we have better tools to select the embryo, we can culture it longer, but there is now lots and lots of data to show that if you put single embryo back versus if you put 2 embryos back, there is no improvement in success rate by 2 embryos. All you are increasing is multiple birth rate, which raises up to 40% if you're putting 2 good quality embryos back. Also freezing, as Colin mentioned, one of the big advantages we have got, that you can have as many embryos as you want, but one by one. So you're not really compromising your overall success rate. We can freeze it, you can come back and have it, and it's a much safer way of delivering. And what we are talking about is not just making people pregnant, we want healthy mother, healthy baby, and healthy families. And single embryo transfer is one of the biggest achievements that we have done.
Kay, how do embryologists in the lab select the healthy embryo or the best embryo? How do they do that?
With great difficulty. But, well, you may, I think about 10 years ago, I co-edited a book which was about how to choose the right embryo. We had 27 chapters written by 27 people, giving 27 ways of gauging which is the right embryo to select. And in fact, none of them have really turned out to be the best. And we've made a lot of progress. We have made a lot of progress in understanding the science behind choosing the right embryo. And there's a lot of very expensive technology involved nowadays. But basically, we still rely on morphological appearance. And in other words, how it looks. The embryo. Is it a good-looking embryo? Alastair was a beautiful 8-cell.
And look how he's grown.
No, seriously, and when in the early days at Bourn Hall, we graded embryos, and this is, I think, came from Jean. We graded embryos as beautiful, nice, okay, lovely, or ugly. And this has been translated into much more sophisticated systems, you know, with letters and numbers and all kinds of parameters. But I know we have embryologists here in the audience. What do you think, Brian? We're still down to how they look, basically, and how they grow, their rate of development, and just measuring and looking at how they're growing in culture.
We have cultures to day 5 now, and that's changed a lot. So we can culture them, we can see the ones that get to day 5, we can grade them at that level, and we can even now, in Glasgow we're doing this, we're actually looking to see if an embryo is going to split into 2 and one a zygotic twin, and if we think that, we don't put that one back. So we can really assess the blastocysts in such a detail nowadays.
Come on a long way. And we've probably got time for one more question if there's a burning question in the room. Down here at the front, Sandy.
Thanks. Hi, sorry, this is probably a really different type of question. My name's Beverly and I'm a solicitor at BTO Family Law. We're currently in the process of implementing a specialist fertility team because quite a lot of the clients that we have coming to us are maybe at the start of their fertility journey where they don't know if they're going to end up down the path of successful IVF or whether they have to look at surrogacy or adoption, and they kind of want to understand what the law is and what's their safest route depending on what their family looks like. So if you have LGBT couples, the law is different from same-sex couples. So basically what I want to understand is what pitfalls in the law are there from your perspective for potential clients, and what areas of the law do you think need to be changed the most in this area?
I think we'd be here till tomorrow morning if we answered that fully, but is there any obvious legal pitfalls for people? Abha, you've got the microphone.
For LGBT couples, when they are freezing their gametes, there are a number of pathways that can happen. And it depends upon really when they come back to use their gametes as to what pathway they're going to go down and what exactly the law will apply. So there are laws about parenthood, legal parenthood is there. There are laws about surrogacy, which are slightly different between England and Scotland. So I'm glad to hear that there is a specialist fertility team being created in the law area. So it all depends upon when they come to use the embryos or the gametes, what the situation is.
Sally, do you want to comment on that?
I suppose what I wanted to say is these days, whatever your family background and composition, there is a way to create the family that you want, and that should be the message that people take away. Whether it's an alternative to a man, a woman and a child, it doesn't really matter anymore, and it shouldn't. And what you need to do is to investigate what might be relevant for you, whether you're single, whether you're in a same-sex relationship, whether you need surrogacy, whether you need fertility preservation, whether you've got genetic disease in your family. All of those, there is now a route open to you. And isn't that a fantastic development from 40 years ago when Grace was brave enough and lucky enough to be able to have treatment, but when the laws first came into place, it was only supposed to be for married couples. So we're in a vastly different era. It's not easy, and some of the laws are complex, some of the areas are regulated and some aren't. But there is a route, and it's about finding out what the alternatives are for you and taking some advice from people in clinics who know what they're talking about and can offer you those options.
Thank you. Unless anyone, Colin, you? Unless anyone has a burning question, we might start the summing up. Okay, it's tradition in a PET meeting that we ask a final question, and we give you the opportunity to sum up. And given that we're here with the title of 40 years past, present and future, what I'd like to ask that each of the panel, from any perspective, it doesn't have to be medicine, it doesn't have to be science, but if we were holding this event in 40 years' time, what might IVF look like, or the world of fertility look like? And I'm going to begin with the UK.
Thank you, Alan. Well, as you know, I have actually been following the science of IVF for almost 40 years. And the science of IVF is my particular interest, my obsession, my passion, I guess. I've been learning and reading and writing about it. And a lot of the IVF, until very recently, has been the systems that we use in the lab have been based on research that was gained from animal systems, a lot of Bob's basic work and many other people as well. Did I mention right at the beginning that Bob started his career here in Edinburgh?
You did.
Did I say
yes,
that?
You did.
Yes,
yeah.
okay. So over the past 10 to 15 years, I became a bit sort of dismayed and depressed by the huge corporate industry that has taken over IVF. It's become a huge, multi-billion-dollar industry, lots and lots of money involved, and this, I think, has diverted attention from the fundamental scientific issues. I was very pleased by the HFEA report recently. I think that's really a fabulous move because, the science behind some of those things. But anyway, what I hope for the future, what I see now, is that the technology has evolved and developed, that we are now in a position to actually start addressing the fundamental questions that Bob was asking 40 years ago. So there are 4 basic areas, and I'm very, very privileged at the moment to be facilitating in research in these 4 different areas. So because we have the technology to look at the molecular biology, the cell biology, and we now have access to applying this technology to human material. So, for example, at Bourn we have a collaboration that's looking at the fundamental cell biology, what happens during meiosis in immature human eggs that are not suitable for treatment. So we're gaining a lot of information about what goes on in eggs, what makes them go wrong, and hopefully what we can do to help to make sure that they don't go wrong. For embryos, patients who have surplus embryos frozen, have completed their family, they have the option to donate this to research. And we have an excellent collaboration with the Francis Crick Institute in London, and they are doing phenomenally exciting fundamental molecular biology work to understand what it takes to grow and develop a normal human embryo. The application of the editing technology, it's not in order to correct these embryos, but it's to understand which genes are necessary to make sure that an embryo grows correctly. So the third collaboration that I'm involved in is looking at the endometrium. We have a collaboration with the Centre for Trophoblast Research in Cambridge. We are giving them endometrial samples, and they're trying to build an in vitro model to mimic implantation. So again, they can study the molecular biology and try to discover what is necessary for implantation or what can go wrong to make it miscarry. The fourth area that's really very important at the moment is because we're understanding a lot more about the biochemistry that is involved, is the impact of the environment and lifestyle. And Colin touched on this a little bit. This is really what we want to know. We want to help people to be their most fertile by understanding the impact of the environment and environmental pollution on reproductive endocrinology. And you know from your field as well that that's very important. So my hope for the future, for the next 40 years, that we'll have a much greater understanding of all of these areas so that we can really do our very best to make sure that everyone who needs IVF can have a healthy baby.
Thank you. Grace, do you have any thoughts or comments about what the next 40 years may hold?
Funny, Kay just took the bit that I was going to say. That the one thing I would like to see is people who really want to have a baby to be able to have that. I know that from what Colin said, that the odds are still 1 in 4, but it would just be such a nice dream to think that that could be shortened and that it could be made possible, that it would be, people would be able to have children.
And that's as much about access as it is about science.
Exactly, yes.
Alastair.
Sorry, not meaning to politicise the event, but the one thing that almost really frightened me a few years ago, correct me wrong if I'm getting this wrong, but I mean HFEA almost didn't exist a few years ago, is that right, if I remember?
There was a discussion, I think, about...
Yeah, and I think
more than one.
Well, yeah.
I was only aware of one.
Yeah, and yeah, I think the one thing that worries me about the future is, as what you touched on earlier, is about funding being taken away from the HFEA, and what if that happened? Like, where would it go? Would it all just become outright big business, just controlling everything, and there'll be no control? I mean, control and care and how the research and how people are treated and how to get their treatment, I mean, is paramount to certainly the ethical and moral and practices that go on to ensure that people can have the child that they desire and want. So I think in my mind the next 40 years are crucial in just ensuring that the HFEA exists in some form, and well, hopefully still is and as well funded as, or is it was well funded, but it's still there and leading the way is what it does.
Okay, thank you.
Right, thanks. Sorry.
Abha.
Hi, from 40 years past, listening to you, Grace, that it was NKU, that it was the American lady who funded that treatment, it was just purely research, to coming to this point that some places, yes, are funding 3 cycles, some are not. My hope 40 years later, if we are having this event, is that IVF is normal treatment. If anybody needs 5 appointments in gynecology clinic, they don't need to think about funding. They don't need to think it's only 3 appointments they can have. So I think there won't be any, hopefully, restriction on number of cycles. People will have the treatment. As Grace, you said, everybody should be allowed to have baby. It's a basic human right. And even WHO has classified infertility or inability to have a baby as disease. So that respect will be given by NHS throughout the UK, irrespective of the number of cycles and treatments needed. So funding won't be an issue, and it'll be part of normal treatment.
Thank you. Sally.
Thank you. So in 40 years, we might have moved so far ahead with the science that you don't actually need a partner anymore. You probably might be able to create artificial sperm or eggs. And I'm not really sure where we'll be in 40 years because the pace of change over the last 5 has been so great. But I think what I would say is that it's very easy to get carried away with the latest research or the latest gimmick that might serve only a very tiny handful of people. And my wish is that we go back, and in 40 years' time we are still doing basic IVF really well, that we're caring for patients, that we're giving everybody the best chance. We will never get to 100% success rate, but that we go back to the fundamentals that we started with, that Grace talked about, that she felt like she was the centre of everything, that she was looked after so well by people who were doing something in their very homemade way, but pioneering. And I think sometimes we're lost in the science gimmicks, and we forget that actually it's about basic care, basic rights, basic access, basic treatment done really well, because they are still the majority of people, despite all of the headlines, who come forward for treatment. They are ordinary people who have a fertility problem who would like a baby. And I think I just wanted to pay tribute to Grace, really, to say how brave you were right at the start to be able to do that. And I hope that people will still come forward to be brave as developments continue. But that actually we need to go back to some of the principles and the values around those days, which the UK generally, not just the regulator, but everybody who works in the sector abides by and wants to live. And that we end up with more people. There was a statistic I quoted in a speech that said we think by the end of the century, now there might be 5, 6, 8, 10 million babies born from IVF. There might be 400 million babies as a result of the descendants of people like you who started it all off. And that would be an incredible triumph if we could just continue that and give all these people a life that they might not have had.
Thank you. Colin.
Well, I hope in 40 years' time there'll be one more trashy crime novel. But actually, in 40 years' time, what I really do hope is that the patients that come to see will have the human contact that the patients currently get. They'll see a caring doctor, caring specialist nursing staff, and caring scientists. That they will look after them in a way where that respects their individuality and respects them. And I think that the big changes in the next 40 years are going to happen behind the scenes rather than in the front of house. And I think the laboratory is the thing that's going to be different.
Thank you. Ladies and gentlemen, we're almost at the end. If I could ask you to thank our panel in the traditional way, but not leave. Thank you. Because I have one final question. Alastair, what did you do for your 40th birthday? Pick up a microphone and tell us.
Other than cry? Or well, we went out for a meal just in Glasgow and things, so didn't really do much. But I mean, I have got a 40th birthday party arranged in a few weeks' time now. I just wanted to get the party out, the birthday out the way, then I could actually come to terms with my age, and then actually celebrate, have one last blowout.
It's fine. Life doesn't stop at 40. But you're having a big bash on the tall ships in Glasgow, I think, aren't you?
Yes.
The tall ship. Well, we couldn't let tonight end, ladies and gentlemen, without at least acknowledging Alastair's 40th birthday, and we have two parts to this. So first, Kay, you, I think, have a gift. If we could get the microphone to... Can we get the microphone to Kay? And you can explain what the gifts are.
No, you have to open them. I'm not going to tell you what it is.
Okay, but once they're open for the
once
audience...
Once they're open, I'll tell you what it is. That one's for both of you, and that one's for Alastair. Okay.
There you go. So, Alastair, if you could open the presents now, that would be great. Your birthday has passed, so we are allowed to do this. Everyone's waited with bated breath. Yeah, tear it. It is, I think, a photo book.
It's a photo album. It's a photo album. We put together as many photos as we could find of the two of you at Bourn Hall, starting from your press photos, 19th of a week old, yeah. And
for Alastair, what is the gift in the box?
What? Do you know what they are? Do you recognise what they are, Alastair?
Could you tell us, Kay?
Well, they're map coordinates. Look on the. Of course they are. You're an engineer. You know that.
And look on the.
Yeah.
And what are they coordinates
Look on the other side. Look on the back of the cufflinks. Okay.
So they are the coordinates of...
The coordinates for Dr. Yeah. The coordinates for Dr. Kershaw's and where you were conceived.
That's me.
And the coordinates for Bourn Hall, because we're your family.
Thank you very much. And of course, no birthday would be complete without a cake, so we have a cake. And I would like to ask, ladies and gentlemen, if you would join me and the panel in singing Happy Birthday to Alastair. Would someone like to lead? That's me, isn't it? Everyone stand. Alastair. Happy birthday to you. Happy birthday to you.